Hi, my name is Eric Albert. I'm going to discuss acute respiratory distress syndrome. Acute respiratory distress syndrome was first founded in 1960 during military times and mostly in Vietnam. It was first known by military physicians as shock lung due to the trauma of warfare. Once it made its way into civilian hospitals, civilian physicians renamed it acute respiratory distress syndrome. This syndrome, also known as ARDS, is an acute inflammatory insult to the lungs that results in alveolar capillary injury and impaired gas exchange. The biggest problem with acute respiratory distress syndrome is what's known as a ventilatory perfusion mismatch. And as we get further into the concept map, I'll discuss what that is. The first thing that I'm going to discuss is the Berlin criteria and definition to diagnose somebody with acute respiratory distress syndrome. The first criteria is bilateral opacities that are presented in chest radiology, whether that is an X-ray, a CAT scan, MRI, or so forth. The criteria is it has to be bilaterally and mostly recognized in the lower portion of the lungs where the alveoli are. This cannot be, what you're really looking for is anything else that explains the person's respiratory distress other than acute respiratory distress syndrome, which could be a pneumothorax, really bad pneumonia, massive pleural effusions, pulmonary nodules, or a collapse of the lung. The second criteria kind of piggybacks off of the first criteria and essentially says that there has to be no other definitive explanation of why somebody's having respiratory distress that may be outside of the lungs, whether it's fluid overload, congestive heart failure, a metabolic process that's causing someone to be dyspneic, and so forth. The third criteria is there has to be present hypoxemia, and there has to be what we said earlier, which was a ventilatory perfusion mismatch. And essentially what that is the amount of arterial oxygen tension compared to the amount of fraction of inspired air. So the amount of fraction inspired air in room air is 21%. But if you're giving someone supplemental oxygen and there's still that mismatch of the amount of circulating oxygen or available oxygen within the blood, then you have a ventilatory perfusion mismatch. If people meet those three criteria, then they can be diagnosed with acute respiratory distress syndrome. This syndrome has 3 stages that people go through. Sometimes people don't go through the third stage, but we'll get into that as I go through the stages. The first stage is the inflammatory stage or exudative stage. And essentially what this is the inflammation response or the nonspecific inflammatory response that happens sometimes anywhere between 6 to 72 hours of the original insult. This creates an inflammatory cascade that happens in the alveolar capillary bed and damages the alveolar cells. What essentially happens is there's cytokines, the interleukin-6, and macrophages that respond to the alveolar beds in the lungs, and they create increased permeability and damage to the alveoli. Specifically what happens is there's alveolar type 2 cells, and those get damaged, and the responsibility of those cells are to produce surfactant. Surfactant is essential for oxygen exchange, and the reason being is it is a soapy substance that is created by these alveolar type 2 cells. And the way I like to explain it is if you take a balloon and you put a little bit of water into it, you'll notice that the 2 sides of the balloon kind of stick together. That happens inside the lungs because the lungs are constantly humidified. The problem being is that creates a problem for alveolar and lung expansion. So without surfactant, what happens is alveolar sacs tend to collapse, and then they stick together, also known as atelectasis. This is the biggest problem with the non-production or the damage to the alveolar type 2 cells, and it interrupts surfactant production. The other problem is because of the increased permeability caused by the inflammatory process is these alveolar cells or alveolar sacs get filled with fluid, which oxygen can't properly be exchanged for carbon dioxide, or what is known as external respirations in the lungs, which leads to hypoxemia, hypercapnia, and dyspnea. The second stage is the proliferative stage. And this is basically the resolution of the initial stage and the reduction of the inflammation and the resolution of the pulmonary edema caused by the inflammatory process. This happens typically between 7 to 10 days after the initial insult or the start of the inflammatory stage. This usually takes about 2 to 3 weeks to get past this stage, and this is very important depending on the mild to moderate to severe damage done during the initial insult. At this time, the pulmonary edema has resolved, and the body's starting to heal and starting to rejuvenate and restore the alveolar cells. And the most important thing is that they return to normal, healthy, functioning cells, and that surfactant production could be restored. If the damage done during the inflammatory stage is too severe, then, or something else happens that, we'll also get into, sometimes people can end up with barotrauma due to the treatment for ARDS. And then if that damage is too severe, then obviously surfactant production isn't restored, we don't have healthy cells, and then you enter the fibrotic stage. During the fibrotic stage, if cells can't be restored back to normal healthy tissue, then those areas become fibrotic and you have permanent lung damage and decreased lung compliance and a perpetual ventilatory perfusion mismatch. These people tend to have really bad outcomes. They have constant, they need supplemental oxygen pretty much throughout their whole life, whether it's PRN, whether it's, constantly, and so forth, and the amount of mismatch they have all depends on the severity of their fibrotic stages, or their sort of fibrotic condition. The classic signs for acute respiratory distress syndrome are dyspnea, tachypnea, hypoxemia, ablate supplemental oxygen, and that's really what we're looking for, is that mismatch of the amount of oxygen that's being inspired and the amount of oxygen that's being diffused across the tissue or alveolar capillary beds. The complications, as we discussed, were impaired gas exchange, decreased lung compliance. Pulmonary hypertension is also an aftermath. It doesn't usually happen right away, but this tends to happen more so in those fibrotic conditions that I talked about, and then respiratory failure and death. There is as high as a 40% mortality rate when somebody experiences acute respiratory distress syndrome, so it is a serious condition, lethal condition, and something that needs to be treated aggressively. Now we'll talk about the management. The basic management of treating somebody with acute respiratory distress syndrome is to protect their airway, increase or supplement, breathing, and make sure that people are getting adequate respirations. And, the main thing you want to do after protecting someone's airway and increasing the amount of oxygen that's available to them is identify the underlying condition. What caused them to have this nonspecific inflammatory response and to precipitate the onset of acute respiratory distress syndrome? If those things are not reversed, then this will kind of linger, get worse, and will lead to a more severe case. There's a ton of things that can cause somebody to experience acute respiratory distress syndrome. Some of that is sepsis, aspiration, trauma, pneumonia, massive blood transfusions, some stem cell transplants, certain medications, long-term or short-term use of amiodarone is another one. Smoke inhalation is another one. So really anything that's going to cause an inflammatory response or irritate the lungs can, precipitate this condition. The main treatment is supplemental oxygen. The most severe cases have to be treated with endotracheal intubation, mechanical ventilations, and some people even end up on ECMO, which is basically an artificial or an exterior lung that oxygenates blood and circulates it into the body. Some of the newer devices that we use to supplement people's respirations, such as high flow oxygen, BiPAP and CPAP, have stopped people from getting intubated. And one of the biggest things that you don't really want to intubate somebody unless you have to, especially somebody with ARDS, is what can happen is trauma to the lungs due to pressure and baroreceptor trauma. This can lead into those more fibrotic stages that I talked about in the third stage of acute respiratory syndrome. People that are on mechanical ventilation and are intubated have very specific vent settings for ARDS. And the two biggest things is low tidal volumes to decrease the chances of those pressure injuries to the lungs and to the baroreceptors. And the other thing is high PEEP. PEEP is essentially when somebody at the end of their exhalation stage is the amount of residual pressure that is inside the lungs. And the importance of keeping that high is that it promotes the alveoli from staying expanded and stopping the collapsing of the alveoli. What we talked about was atelectasis. And a lot of that has to do with the decrease of the surfactant production. So without the surfactant, those alveoli don't stay expanded. And so increasing PEEP promotes those alveoli from staying expanded. The other thing is what is known as prone positioning. And there's been some conflicting reports out of how beneficial that is to patients, but what they found is that it increases the amount of volume that can be inspired into the lungs. It takes the weight of the heart off of the lungs. And for some reason, it improves the ventilatory perfusion match. It prevents the amount of inspired air and the amount of oxygen available within the lungs. There isn't too much that I've seen as why that happens with the prone position, but they just know that when people are in prone position, that the match between the ventilations and perfusion improves. The other thing is if people are intubated, there have been better outcomes and better prognoses with people that are on long-term paralytics or neuromuscular blocking agents. It allows the body to work less, it improves lung compliance, and allows the ventilations to kind of take over and allows the body to kind of, spend its energy helping heal. So those are really the biggest things is aggressive airway management with supplemental oxygen, whether it's a nasal cannula, a non-rebreather, a simple mask, high flow oxygen, BiPAP, CPAP, endotracheal intubation, or ECMO, depending on how severe the trauma and the inflammation process is to the lungs. I hope this was informational and gives you an overview of acute respiratory distress syndrome. Thank you very much.